Hello, and welcome to the Chest Critical Care Podcast, where we host a discussion with the authors of important articles from the journal, adding context and commentary to the challenges facing clinicians in the field of critical care medicine. To introduce today's topic, here's your host, Dr. Dan Fein.
Hello and welcome to the Chest Critical Care Podcast. I'm Dan Fein. I'm an adult pulmonary and critical care physician at Montefiore Einstein in the Bronx, New York, where I'm also an ICU director. I'm an associate professor of medicine at the Albert Einstein College of Medicine, and I'm one of the editors here at Chest Critical Care. This is our first episode of the Chest Critical Care Podcast, where our goal is to bring you perspectives from the latest and greatest content being published in Chest Critical Care. I'm so happy to be your host for today's episode. We'll be looking at the association between mechanical power and ventilator-associated lung injury. We'll look at how this relationship may help us better understand what parameters really matter when you're at the bedside of a sick patient with respiratory failure. We're joined by authors and editorials from a recent article published in Chest Critical Care titled "The Impact of Mechanical Power to Normalize Predicted Body Weight on Outcomes in Pediatric ARDS." We'll also hear from editorialist who looks at a compelling new framework for thinking about ventilator-associated lung injury. While this paper is focused on a pediatric population, I want to do our best to make our conversation applicable to both pediatric intensivists and adult intensivists like myself. I'm really excited to start talking to our authors and editorialists today. So would each of you mind introducing yourselves? I'll start with Herng Lee. Can you tell us a little bit about your current role, your research focus, and where you're joining us from?
I'm joining from Singapore. I'm a respiratory therapist working at KK Women's and Children's ICU and also part of the time spent in the neonatal intensive care unit. My interest is more towards pediatric mechanical ventilation.
That's great. Thank you. And Judith, the senior author on the paper, tell us a little bit about yourself.
Hi, Dan. Thank you for the opportunity to share our work in greater detail. As with Herng Lee, I'm from KK Women's and Children's Hospital in Singapore. I'm a pediatric intensivist, and I have a similar research interest in pediatric mechanical ventilation, and in particular, pediatric ARDS.
Thank you so much. And Vicent, tell us a little bit about yourself.
Hi, I'm Vicent Modesto from Spain. I'm responsible for the intensive care unit in Hospital Universitari y Polytechnic La Fe in Valencia, in Spain. My focus of interest in investigation is mechanical ventilation in children, and specifically the new ergotraumatic theory about VILI production.
Thanks so much. We're looking forward to hearing more about that. So, Dr. Wong, could you start us off by briefly summarizing your research question and the key findings for our listeners?
Okay, briefly, our study utilized a multi-center data set to describe the relationship between estimated mechanical power and clinical characteristics and outcomes in pediatric ARDS. In general, younger children and those with higher peds ARDS severity had higher normalized mechanical power. We also found an association between higher mechanical power and poor clinical outcomes, including ICU mortality, ventilator-free days, and ICU-free days. And lastly, we found that the effect of mechanical power on outcomes was mediated by impairment in oxygenation. So that's it in a nutshell.
Yeah, thanks for summarizing that. And we'll get into all your findings in more detail shortly. Whenever I hear about a paper, it always helps me remember the findings if I know what the inciting event for the research was. So was there anything that happened at the bedside or with a particular patient or in the progression of your research that prompted you to look at this question further?
For us, it has been, especially in pediatrics, always challenging to grasp the concept of ventilator-induced lung injury because it's something that can't be directly measured. And our group has been interested in studying the effects of mechanical ventilation in children for a while, especially in the setting of peds ARDS. So when mechanical power was introduced and proposed to be harmful in the adult population, as well as in many very nicely designed animal models, we found that there was a lack of data in children. And we had just completed a study on lung protective mechanical ventilation, and we had a granular sort of data set and with an expected wide variation of mechanical power. So we kind of undertook this study in an opportunistic manner.
All right, that's great. Thanks for sharing that. So, Herng Lee, for those unfamiliar with mechanical power, how would you describe it to them, and what does it represent physiologically?
Mechanical power is the energy dissipated to the lung parenchyma from the ventilator within a given time frame. So originally developed, it can be calculated using mathematical formula and estimated using the simplified model which we use for estimating mechanical power in pressure control ventilation. Importantly, the mechanical power is related to the development of ventilator-induced lung injury.
All right, great. And in your title, you guys talk about the idea of normalization of mechanical power. Why is it so important to correct mechanical power for patient-level factors?
I think for children is because the two key components of mechanical power, the respiratory rate and tidal volume in children are age-dependent, making detrimental thresholds for mechanical power uneven across the pediatric age range. Thus, some form of normalization of mechanical power was needed. We chose to normalize the mechanical power by ideal body weight using the WHO growth standards. However, we did not normalize the respiratory rate. This was because there was no acceptable ways to normalize the respiratory rate. We did perform a subgroup analysis for children aged more than 2 years old and then less than 2 years old.
Okay, interesting. Thank you. So one thing I learned through reading your paper is that pressure control ventilation is very commonly used in the pediatric population, which contrasts a little bit to the adult population, at least in the United States. So did this use of pressure control ventilation induce any specific challenges in your study?
Yeah, so the formula actually volume control ventilation came out first, and there's a lot of variables needed, and it's a complex formula. So when Beecher came out with the simplified formula, we also decided to embark on this study. And the challenges is mainly deal with the plateau pressure measurement, which is seldom done in children, and we elected to use the peak pressure over the plateau pressure. Yeah.
Okay.
I think just to mention, for children, pressure-controlled ventilation seems to be more widely used. This is not unique to our cohort. Many other cohorts, whether it's in North America or international cohorts, they also report a higher usage of pressure-controlled ventilation. And I think at least for pediatrics, there's no mode that is considered superior, whether it's volume or pressure control. So it's really the preference of the intensivist to pick a mode that they're more familiar with.
Yeah, for sure. So I think in the adult population as well, there's no definitive data, but it more becomes down to practice patterns.
Yeah.
It's probably because we are accustomed to use pressure control modes because we came from the neonatal field in the beginning of the pediatric intensive care. But I'm not sure that it's superior pressure control to volume control modes, especially if you trust in this theory in which one of the problems is the strain rate. Probably control ventilation with a steady velocity induces less strain rate. So probably this is one of the opportunities to study if this myth of superiority of pressure control is going to be put it in question. So for me, this is an opportunity.
Yeah, that's interesting. And what do you guys think for our adult intensivist listeners? Do you think that the findings are limited because of the predominant use of pressure controlled ventilation, which may not be applicable as much to the predominant form of mechanical ventilation in adults?
I don't know exactly because this was the first development of a formula in Gattinoni's paper. And I think it's because it's easy to do the maths with a constant flow. taking into account only a number in flow and not time-dependent function in the flow. But I think it's important to notice that this is not the formula is not the result of regression analysis. It's only a mathematical formula deduced with a geometrical argument. So there are some of the elements of the formula that are in relationship between them. It's not individual factors that contribute to the mechanical power. It's better, a geometrical approximation of the energy that is introduced in the lung in one ventilation. So that's a tricky, a very important aspect of the formula. Probably in the future, when we have the new formula about this same concept in pressure control, it will be interchangeable between the two magnitudes. But now we are sure that the definition is only in volume control, and it's important that you have to measure mechanical power during the holdings of the mechanical ventilator. So it's important first to know that this is only a mathematical approximation of a geometrical concept, and second, you have to do the holdings to compute the mechanical power.
And when you say holdings, do you mean measurement of plateau pressure? What are you referring to when you say holdings?
Yeah, and total PBS.
Okay. And I guess just back to the authors, you guys in the pediatric population did not have available measurements for plateau pressure. How did this change your analysis and how you interpret your results?
I think one thing I would like to mention is that the formulas, even the simplified formulas for mechanical power, whether it's for volume control or pressure control, they have been quite exhaustively validated in adult populations. And the validity of the formulas, I don't think we would question that. I think they're quite accurate. Maybe there could be a slight underestimation using the simplified formulas, but it's a systematic underestimation. I think the bigger difference would be the pediatric and the adult lung mechanics and the susceptibility to ventilator-induced lung injury. So if you're asking about whether our results are applicable to adults, I think it's more the patient substrate rather than the calculated number of mechanical power that is applicable or not to the populations.
Okay, thank you. So let's get a little bit into the results and interpretation of the findings of the study. So, Dr. Wong, which mechanical power metric, which part of the formula was most predictive of outcomes and why?
Actually, the role of individual mechanical power components, how they affect the outcomes, wasn't explicitly studied in this paper. I'm aware that in the adult literature, driving pressure and respiratory rates are quite closely associated with outcomes. But for children, we didn't particularly look at it in this paper, but in the secondary analysis from the PADI study, which I think Vicent may have been involved in, they didn't find any single ventilator variable that was associated with outcomes. But mechanical power as a composite variable was associated with ventilator-free days. So we didn't particularly look at this individual component, but I think in the future, it would be quite interesting to model how the changes in these individual components can change the mechanical power, and that will help us sort of develop an algorithm or a method to improve the way we ventilate children in the future.
Yeah, that's really interesting that the components themselves don't necessarily predict your outcomes, but when you put it all together, mechanical power itself does, thus making it all the more interesting as something that we should look at.
Yeah.
And how did you guys adjust for severity of illness and other confounders in your study?
Well, we found there was a strong association between mechanical power and outcome in the multivariable models, and we adjusted for the severity. So we did this by including the Pediatric Index of Mortality 3 score, the Pediatric Logistic Organ Dysfunction 2 score, PEDS ARDS severity itself, as well as confounders like age. And in the mediation model, we also looked at stratification by ARDS severity.
Okay, great. And do you feel like the amount you adjusted and what you adjusted for was effective to demonstrate your results?
Yeah. So these variables that I just mentioned, they were all associated with outcomes, and of course, a combination in the model, in the multivariable model, produced quite a strong area under the curve for the outcome of mortality. Adding mechanical power to the model actually improved it significantly. In fact, of all the variables that I mentioned, the mechanical power was the strongest association with mortality or with outcomes.
Yeah, that's interesting.
I think one of the strengths of the author's paper is that they are looking for causality. You know, we have a great association in multivariate models. Association is no causation. You know that old phrase. But they did a very interesting effort in trying to transit to the causality of the problem, and they use a modern causal statistical analysis with a modification analysis in which they discovered that mechanical power is not producing the mortality with a direct effect, but rather in an indirect effect through intermediate variable that is oxygenation index. I had some issues with the oxygenation index because there's a mixture of two information. One is the PF ratio, so is what is the physiopathological entity of the severity of the patient, and the other part is mean airway pressure that can be altered, can be changed, but some doctors miss ventilation of the patient. So it's a number that is very well related with the prognosis, but with two sources of information. One is how is you doing the ventilation, and the other is how severe is your patient. But the analysis shows nicely that there is no direct effect with the energy, but direct effect through intermediate variable, that is the deterioration that this energy is producing in the oxygenator of the body of the patients. I think that's a very interesting discovery and a very interesting idea.
Yeah, I was really surprised by this finding, just because in a lot of the big adult ARDS studies, oxygenation has been found to not really be correlated closely with organ failure and mortality.
Yep.
So I wanted to ask the authors what they thought about this contrast with the adult literature. And it surprised me, and it made me think twice about whether we should be paying more attention to oxygenation, or whether pediatric and adult patients are in fact very different in how the lungs are impacted and the parameters we should be looking at. What do you guys think?
As far as I'm familiar with the literature, children seem to have a strong association between oxygenation and outcomes, and it's not unique to our cohort. So other PEDS ARDS cohorts also show a strong association between oxygenation and outcomes. And I'm just thinking oxygenation is quite a direct measure of the lung injury, and it's an important cause of multi-organ dysfunction and death. But multi-organ dysfunction can also be caused by other pathways. So, for example, in patients with multiple comorbidities. So it may just be that this is more prominent in adult populations than in children, populations with multiple comorbidities.
Right. That makes a lot of sense.
It's just a speculation.
No, that does make sense, though. Thank you. So, just thinking about clinical translation more, one thing that really struck me is that an important part of the formula for mechanical power includes respiratory rate. And generally, at least in adults, what we're doing is using very high respiratory rates to compensate for low tidal volume ventilation, to maintain minute ventilation to some degree. And even though we allow some degree of hypercapnia, we try often to increase the respiratory rate to offset it to some extent. Do you think that given this finding of mechanical power being associated with worse outcomes, we should pay more attention to respiratory rate and that we shouldn't be cranking up the respiratory rate in patients with ARDS?
Yes, I think there are two new variables that we are going to be very, very conscient. One is the respiratory rate, and the second one is the flow of the curve of the introducing of the air. Respiratory rate is true that we use more respiratory rate to try to reduce PCO2 in our patients. But if you think deeply in this, nor barotrauma, nor volutrauma, nor atelect trauma predicts anything about the respiratory rate. But the evidence shows that permissive hypercapnia goes to better results. So probably empirically, you have to add some theory to the old theories about the villi production. This new theory integrates all these concepts in only one. If you use less energy to ventilate your patients because you introduce less times air in the lung of your patient, is less mechanical power, so probably less villi in your patient. And that makes sense, I think. And also the problem with the flow, because, the flow was the elephant in the room. Nobody thought about the flow in our curves. But there are a lot of physical evidence about, physics of materials and the breaking of some buildings and breaking of some bridges, that it's very important that the deformation is done very rapidly. You probably will have a more damage in your material. Think for instance, in the Karatikian, in breaking a brick with low force, very low force, but rapidly introducing the deformation. And that's not our old theories about villi formation didn't have this into account. This new theory, ergotrauma, introduces these dynamic causes of energy in the conversation, and probably they are more and more important in the production of villi. And even we are explaining with this theory other empirical evidence. For instance, the permissive hypercapnia in our patients.
Yeah, thank you, Vincent. So just for the listeners as well, I would look at Vincent's editorial to further go into the ideas regarding material science and how it relates to ventilator-associated lung injury. So, Vincent, a lot of these concepts are unfamiliar to many intensivists. I took one material science class in college, but I never thought to apply it to the ideas that we commonly talk about in ventilator-associated lung injury and mechanical ventilation. Where did you learn about this, and where did you
Yeah, me too. But now in cardiology, you are going to do echocardiography, and then they explore the myocardial infarction, saying, "Oh, this is the strain rate of the tissue." What is exactly strain for the classical physiology? That's not a concept in classical physiology. We have tidal volume, we have functional residual capacity, but we don't have a concept with the mixture of the both, and it's very important for material science, the strain of one material. the deformity induced in the material by a force, but taking into account the beginning of the shape of the object is, for instance, the same tidal volume can produce more villi if you use low PEEP. How do you interpret this concept in the classical physiopathology of the? We didn't have any explanation, but now if you relate the strain to the production of villi, probably a strain is a high tidal volume with a low PEEP is a very high strain that produces villi directly because of the strain. So the problem is we didn't have these concepts in the classical physiology. I think this is a shift in paradigm. We need to understand some concepts of material science, and probably we have to translate the old physiopathology of the lung diseases in this new paradigm. You are using strain in echocardiography. You are using strain on a lot of parts of the modern medicine. So let's introduce these terms in our classical lung physiology.
Yeah, great. Thank you. So, Herng Lee, if, like Dr. Modesto is saying, we should be totally shifting to talking about ergotrauma and thus mechanical power, is this feasible at the bedside? Can clinicians actually calculate this while they're taking care of patients, or is this just something that you can do in a data set when you're doing research?
I think we can still calculate at the bedside. It's a little bit more tedious. Definitely would be helpful if the formula can be integrated into ventilators. I do know that Hamilton C6 is coming up with the software to incorporate mechanical power calculation in. So then that would help clinicians at the bedside to decide which components, if they do adjust vent settings, pressure, RR, or even tidal volume, which one contribute more to mechanical power and allow us to personally adjust based on the patient's requirement to reduce mechanical power. So we can look forward to integrating into the ventilator software in the future.
All right, awesome. That's exciting. Looking forward to that.
Yeah.
So, Doctor, anything else about that topic?
Yeah, and also I think we have to do the research to introduce in even in the prognostication of our patients. For instance, do you think it's necessary to maintain a very high mechanical power ventilation of a very severe ARDS previous to put that patient in ECMO? Or probably it's better to know, yes, I can do this ventilation with so high energy in the process that probably if we change to ECMO, cannulation and ECMO, probably we have all this research is going to probably have to be done in the next future. But I think it opens a window of science in our decision of these important areas in our field.
So what you're saying is maybe we should be targeting lower mechanical power prior to putting a patient in ECMO. We shouldn't stress the lungs so much and bring them to the point of injury.
We don't have the data now, but probably it's a good field of investigation for the taking those important decisions in our normal life.
Right.
We are using, for instance, in pediatrics, oxygenation index to take in account to have some decisions to ECMO. But I have some issues with oxygenation index. I think the problem is elegantly more being answered with the mechanical power. It's like you are in the normal conversations. You use, we we are putting a lot of energy to ventilate these patients. Probably it's better to go to ECMO. It's the same, but with numbers, with science below.
Right. So along those lines, Dr. Wong, what's next for your research group? Are there any plans to prospectively validate this data or, as we were just talking about, implement it in the bedside?
Yeah, we envision the next step to be the development of an algorithm to minimize mechanical power. And I think it really needs to be implemented in the randomized study design. But we need to work out if this is feasible. RCTs are expensive, and I really hope if we can tie in biomarkers of inflammation and lung injury into this kind of study. But short of that, as we were discussing earlier, modeling the effects of changes in tidal volume, driving pressure, and PEEP adjustments, how this affects the mechanical power. This may be something a bit more feasible with large data sets. And I believe there have been studies that show that reducing tidal volume, for example, is more efficient in reducing mechanical power than reducing, for example, respiratory rate. And there may be some variables which are more effective in reducing the overall mechanical power than others. So doing these modeling studies prior to developing the algorithm or doing the RCT is probably more feasible.
Okay, great. Looking forward to that, especially in the context of what we were talking about before regarding the concerns regarding high respiratory rate.
Yeah.
So is there anything for the authors that I didn't ask you that you wish I had brought up?
I think an important point is to just say that the study doesn't prove the causation between mechanical power and outcome. It presumes the causation of a model hypothesizing that the oxygenation impairment mediates the effect of MP on outcome. So there are some strong assumptions made in the analysis. So just to state this, it's reported in the publication, but the analysis sort of assumes that there are no unobserved confounding. So if there were unobserved confounders, it would need to have a high risk ratio of at least 2 above that of mechanical power to explain away the effect. So this is one of the assumptions, and it's quite an important assumption. And the second assumption is that we hypothesized a mediation model with a specific causal chain. So mechanical power influences oxygenation, and oxygenation influences outcomes, and mechanical power also influences outcomes. And these relationships are assumed to be unidirectional. So we are confident that if the assumptions are met, that the results would be valid and true. But just to say again, these are quite strict assumptions, and probably in real life, it will not be perfectly met. So that's just the caveat to the analysis.
That's okay. I appreciate you saying that. Can you one more time, though, just summarize as we wrap up for our listeners what you want the take-home message to be from your article on this podcast?
Yeah, sure. So mechanical power was associated with high mechanical power was associated with reduced ventilator-free days and ICU-free days. And oxygenation impairment was shown to fully mediate the effect of mechanical power on these outcomes.
That's great. Thank you. So thank you so much to our guests for this engaging and insightful conversation. For Judith, Vicent, Herng Lee, your perspectives on mechanical power and ventilator-associated lung injury will hopefully help us think beyond traditional parameters that we often look at the bedside. So whether you're working with adults or children, these discussions will help bridge physiology to bedside practice and help us move closer to more nuanced ventilator management strategies. So to our listeners, we encourage you to read the full article and accompanying editorial at Chest Critical Care. We welcome your feedback, questions, or ideas for future episodes. You could feel free to reach out to us either through Chest or on social media. Thank you again to our guests, and thank all of you, the listeners, for joining in. See you next time.